Ladies and gentlemen, so I am doing a mathematical model of obstetric fistula cases, and I'm assessing the number of obstetric. Sorry, I'm
Vic,
assessing the
do
number
you want to
of.
put it in the presentation mode, slideshow?
Oh, sorry. Presentation. Sure. Is it now in full slide?
Yes, it is. Thank you.
Okay. So I am doing a mathematical modeling of obstetric fistula cases, and I'm assessing the number of obstetric fistula recoveries among teenage girls across different places of delivery. So obstetric fistula is an abnormal opening between a woman's genital tract and her urinary tract or rectum, and it's usually caused, or it usually comes from prolonged or obstructive labor during childbirth. The prolonged or obstructed labor can be a cause of any of the 4 delays. And during this period, the pressure of the baby's head presses against the mother's pelvis and causes the tissue to die or fall away, leaving a hole, which is called the fistula. This fistula ends up causing uncontrollable urinary inconsistence and can also cause feces to leak. So there are different types of fistula. We have the vesicoterian fistula, which is between the blood and the uterus, the vesicovaginal fistula between the blood and the vagina, the urethrovaginal fistula, which is between the urethra and the vagina, and also have the rectovaginal fistula, which is between the rectum and the vagina. So this study is going to look at fistula as a general and not a specific type of fistula. And in some cases, more than one type of fistula can occur, and damage could be severe in such a case. So fistula is highly preventable, and some of the prevention measures could be delaying the age of first pregnancy, and the other one could be timely access of obstetric fistula. But on the other hand, fistula can also be treated, but it can only be treated by emergency obstetric surgery, among others. But in also some cases, I forgot to include the point, but some cases where fistula can heal on its own. So statistically, approximately 2 million women worldwide live with untreated fistula, and that is mainly in sub-Saharan Africa and Asia. And annually, we get about 50,000 to 100,000 new cases globally. When it comes to Uganda, we have an estimated 200,000 women who currently live with fistula, and about 1,900 new incident cases annually. These are statistics that are provided by Ministry of Health from 2011. So despite the advancements in accessibility and treatment success, a significant number of affected women still face barriers that can help them prevent or treat fistula. Awareness of obstetric fistula is basically low, mainly in developing countries, and it is also backed up with different misconceptions that are linked to local myths. And these different misconceptions and the low awareness have led to many women delaying to seek treatment, and they end up enduring decades of suffering, as evidenced by the UDHS survey in 2011. Fistula accounts for about 8% of maternal deaths, and it also accounts for about 90% of stillbirths in women. So this research seeks to evaluate the occurrence of obstetric fistula among teenage girls who are aged 15 to 19, and which I am looking at different places of delivery, like the public facilities, private facilities, and on low-key home deliveries. It aims to analyze the potential impact of altering the distribution of delayed deliveries that result into fistula across public and private facilities among girls aged 15 to 19 years I'm not majorly going to look at home deliveries because the major treatment for fistula is basically surgery-based and very few cases heal on their own. So I'll majorly be looking at alterations between public and private facilities. The objectives will be to determine the prevalence of obstetric fistula cases among teenage girls or adolescent girls aged 15 to 19 years. And I'll be examining the variations between the public and private delivery settings. And then I'll also evaluate the potential impact of alternate distributions of the delayed deliveries that result into fistula across public and private facilities among girls aged 15 to 19 years. So to answer my first objective, which is the prevalence of fistula cases among girls 15 to 19 years, when we look at public facilities, we have about 58% of fistula cases occurring in public facilities and about 42% of fistula cases occurring in private facilities. So some of the assumptions that I'm looking at in my model assume that all the model parameters remain constant over time. Assume that the girls do not get pregnant again until they're above 19 years old, so there won't be a recurrence. And all other delivery options, which include home deliveries, traditional healers, among others, are all included in the home delivery compartment. Then in my model, if I look at the model, I have 6 compartments where I have the S here, which represents the susceptible population. And these are the girls that are aged 15. So the pregnant girls that are aged 15 to 19 years old. Then I have the exposed, which is the E compartment, which represents the girls that are experiencing prolonged labor. Then I have the IP, which represents the girls that deliver at public health facilities. The IR, which represents the girls that deliver at private facilities. And the IH, which represents the girls that deliver at home or elsewhere. Then I have R, which represents the girls that recover from fistula. So these are the different compartments. S, the girls that are pregnant. E, those that experience any of the delays or prolonged labor. IP, those that give birth in public. IR, those that give birth in private. IH, home or elsewhere, and then those that recover. As I mentioned earlier, I do not have a reoccurrence since I assume that the girls do not give birth again after they leave until they leave the age bracket. So some of the descriptions of my parameters. At the beginning, we have beta N, and beta N is the rate at which girls become pregnant, teenage girls get pregnant, which according to Ministry of Health is 0.25. And this was multiplied by N, which is a hypothesized number of teenage girls according to the UDHS. So I multiplied these two to get the rate of girls that are entering the susceptible population. And then I have a constant death rate across all the different compartments, which is middle. This is the constant death rate of, the morbidity among teenage girls. Then moving from S to from the susceptible to the exposed compartment, or the pregnant girls to those that experience delays or prolonged labor. I'm having a rate of lambda, which is multiplied by S. And in this case, lambda is the rate of girls that experience prolonged labor, which is 0.6. And this was gotten from a paper by Mark K. Lapopens. So this rate was multiplied by the population in the susceptible compartment. Then from the exposed, or the girls that face any of the 4 delays or all, I have them being distributed to different delivery facilities, where I'm having the public facility, the private facility, and those that deliver at home or elsewhere. So the rate of moving from, for example, the exposed to giving birth in a public facility, to giving birth in a public facility when you have fistula, getting fistula and give birth in a public facility, I have the theta P. Theta P represents the rate of which the girls get fistula in a public facility. This multiplied by the number of people in the prolonged labor compartment and multiplied by alpha, and alpha represents the rate at which the girls give birth in the public facility. So this is a combination of two rates and one population, the rate of getting fistula in a public facility and the rate of giving birth in a public facility. This also, the same also applies to the private facility. We have the rate of giving birth in a private facility and the rate of getting fistula in a private facility. And the same applies to the home compartment, the rate of getting fistula, giving birth at home, multiplied by the exposed population. Then moving from each of these compartments, we have rates of recovery, and each compartment had its own rate of recovery. So here we have the rate of those that are infected with fistula and give birth in a public facility being multiplied by those that recover, and the same applies to private and home. Then I have the recovered compartment. So these are the different equations that basically summarize the transitions between all these compartments. So these are just the descriptions, which are similar to what I've just been explaining here, just emphasizing the different parameters that I used to develop the model. So after doing the model, I came out with some model outputs, which are based on scenarios, where I have the initial scenario being the initial proportions, which still included home deliveries. So in my initial scenario, I used the initial proportions that I got from prevalence, this prevalence. That's what informed my initial scenario, where I had 42% of the births being in public facilities. So if 42% of the births with fistula being in public facilities, and 58% of the births with fistula in private facilities. So I went ahead and modeled different scenarios where I altered different percentages. But as I said, I was going to leave home out because there's not sufficient data to inform home deliveries. And since I'm basically looking at the treatment of fistula being surgery, I'm considering that surgery is not applicable to home delivery. So I went ahead and modeled different scenarios, and these were the model outputs. In my initial scenario, where I had 40% in public facilities and 58% in private facilities, then being at home. So in this scenario, I had a general peak of about 28%, which the time down is in years. So would have a peak of up to 28% cases in about the third year, but then we'd see a reduction in the cases if we're having recoveries or treatment being done in private hospital. Then in scenario one, which was my first hypothesized scenario, I equally distributed the cases in public facilities and private facilities. And in this scenario, at about year 4, we'll be seeing 25 cases, but with also a good recovery. Then in scenario 2, having 30 births in private facilities and 70 in public, we'll see a peak of about 32 cases in public and 8 cases in private, but then this will give us a total number of 40 cases. Then in scenario 3, when we're having 70% of the births in private and 30% in public, we would see 18 cases in public, 15 in private, but a total number of only 33 cases. And then in scenario 4, where I have 90% of births in private and 10% in public, we would see basically a total number of only 29 cases, with 5 in public and, so with 5 deliveries in public and private, 24 deliveries in private facilities. So a summary of the observation of number of cases at the time when peak levels are reached. When you look at the initial, we had 41%, scenario 1, where we had the equal distribution, we had 37. Scenario 2, 70% in public and 30% in private, we had 40 cases. Scenario 3, 30% in public and 70% in private. We had 33 cases, and scenario 4 only had 29 cases, meaning that the more we advise teenage girls to give birth in private facilities, we would be seeing a lower number of fistula cases. So the interpretation from the model output, we see that the fistula cases decrease with an increasing number of girls delivering from private facilities. And this means that private facilities are probably handling the cases of prolonged or delayed labor better than public facilities. And this could be attributed to some structural factors in private facilities that decrease the risk of fistula, like having better or more skilled birth attendants, having better obstetric fistula care, and probably the private facilities could be within reach to these pregnant mothers, and that also comes with affordable transport, among others. Some of the recommendations, the structural risk factors of fistula between public and private facilities could be compared to assess what is informing the difference in performance. And another recommendation is to see if the services in public facility is to have the services in public facilities improved to be as good as those in private facilities. Then probably could see more cases being prevented and recovered. Then we can also look at more studies can be done in the social factors that increase the risk of fistula. Then furthermore, or more specific recommendations, you can have Ministry of Health encourage monitoring and tracking of labor progression in public facilities, especially the public facilities in lower settings. Then we can have the Ministry of Health with funding from the United Nations Population Fund, maybe fund and encourage midwives to use photographs in facilities, most especially the facilities in lower settings. Then we advise MAC School of Public Health and researchers to do some more comparative studies on the maternal health services that are comparative studies on maternal health services between public and private facilities. Thank you.
Yeah, thank you so much, Victoria, and thank you so much for keeping time. You've used 20 minutes, and so you give us a lot of time to give you feedback on your model and to see how you can finalize your project. I'll open the floor to the fellows, and then I will give chance to Robert later on. But let's begin with the fellows. Colleagues, let's give feedback to our colleague, because this should be towards the end of her work. She should be getting to the manuscript writing, and should be getting into the policy drafting, since the fellowship is ending this week. So members, just raise your, I think no need for raising your hand, just unmute and speak. Yeah, Rebecca, go ahead.
Thank you so much for the wonderful presentation. I think that your work flows, and easy to follow, and you clearly put in work to present to us. So thank you. Just a few comments. I think that for the first part, especially for a presentation on literature review, introduction, I think that you can make that more concise, maybe leave it for your report or manuscript. Secondly, first, could you go back to your model assumptions, the slide that has the assumptions? That one. So it says that the girls are assumed to not get pregnant. Okay. Sorry, I hadn't read that properly. Then, so maybe I didn't understand. The cases are for the fistula cases are for the entire Uganda.
Yes, according to UDHS, I just used the proportions from UDHS.
It seems it doesn't. It seems that the numbers are too low. How can there be? You are in the 20s over the entire Uganda. I was when I'm in Kagando would have as many as, I don't know, 50 fistula cases coming for repair in a day. So I don't know that we can be that low in your results.
From here.
Victoria, just get a notebook.
Okay.
And because we're going to give you a lot of feedback today, and we want you to go and sit down, address them, and progress your project forward. Take as much feedback as possible. Rebecca, you continue.
Yes, in the results, the cases that you are presenting, the number of cases over
it's probably
the
because
results.
I considered lower population.
Pardon?
Susceptible. It's probably because I compared a lower susceptible population. Remember, most of them
Yes,
are
maybe you need to adjust that, because the cases over the entire Uganda, I think they're much higher than that. Also, in your interpretation or discussion, if you could go to interpretation or discussion. Oh, also, before you go to interpretation or discussion, what informed your cutoffs? Say 70, 30, 30, 70. Were they arbitrary, or you based them on something? The scenarios, the cutoffs.
I didn't really have a guide. I just kept altering different. And so I picked out these ones because they showed significant differences.
All right. First, go to your interpretation and discussion. Sorry, go ahead. Next slide. So go back. The previous slide. Yes, that one. So you're making assumptions that private health facilities the structural factors in private health facilities more skilled. I don't know that from your study you can make interpretation that they have more skilled birth attendants, better emergency, unless you got that from your results. If you're basing that off of research, then you should let us know. But the way you are presenting, it's like you're certain It's sort of like you're making a causal inference, which I don't know that you can get from your study. So maybe what you can, and this carries on to the recommendations. Maybe what you can tell us is maybe studies to find out why private facilities are doing better than public facilities. But unless you have studies that tell us why, I don't know that you can make these extrapolations.
Oh yes, I had
That
there
is
was a
both.
study that I based on to pick that out from. Maybe I just didn't reference it. I'll add the reference. Thank you for that.
All right. Thank you. Overall, it was a very good presentation, and I have learned a lot from you. So thank you.
Welcome.
Rebecca, thank you. Letitia, go take it on.
Yes, thank you very much. Hope you can hear me.
Yes, you can.
Letitia, yes.
Yes, again, Victoria, thank you for the very good presentation. Coming next, being that I'm going to present next week, trust me, I'm going to pick a very big leaf from you. So my question and my concern was with the graphs. There is a graph that you first showed. It's a bar chart. Yes, I just wanted to know, maybe you could give us some bit of this, why you picked the data, because we're not quite sure of where this data is coming from. Or could at least inform us about the from somewhere. We need to know where these numbers are coming from. Then also, I have a problem with the sample, the number of susceptibles that you picked, because clearly, if you look at the statistics of the fistula cases in Uganda, they're really more than that, unless you really considered some small site that you're looking at, but the number of susceptibles that you started from don't reflect figure of the cases in Uganda. Maybe we also need to adjust that as well.
Thank you so
Yes,
much.
otherwise,
Yeah.
thank you very much. That's all.
Thank you so much, Letitia. Lydia, take it on.
Thank you so much. Victoria, thank you for the wonderful presentation. I just wanted to get clarity on scenario 0. Could you please just scroll to that slide? When I looked at the rates that you are using, scenario 0, I see we have 42%, 58%, and then 10%. So I just wanted to kind of get clarity. Is like the rates that you're using, are they supposed to add up to 100, or are you looking at individual like the health facility births in private and then in at home? I'm looking at them and I see they are beyond 100. So I'm just wondering how you calculated them, because my expectation was probably public and private could give us like a total that we could add up to the home deliveries to give us 100%. So I wanted to just get clarity on that. Otherwise, thank you for the presentation.
Yeah, thank you so much, Lydia. Any other member in the... Okay, Rebecca has also said also the private facilities you are looking at are hospitals or private health facilities. The lower private health facilities, I think, have poor birth outcomes. We need to define what we mean by private and public. Very impressive. And actually, you people are capturing some of my feedback that I was going to give to Victoria. Robert, do you want to give suggestions to Victoria? Then I close it up.
Yes, thank you, Abel. I have a number of points. First of all, can you hear me?
Very clearly, yes.
Yes.
Yeah, first of all, allow me to thank Vicky for the fact that she's come. I can see the project has really grown and improved in terms of the flow, the logic, and the mathematical components. So, Vicky, I will start on I think there's a slide where you shared the rates. Yeah. So first of all, let's go to your diagram, model diagram. Yeah. You see, when you mention a rate, go back to the document, the page that has the rates. Mathematically, you have to define the unit. So, and rate is denoted with time. So, this appeared to me more of proportions than rates. But if it's a rate, well and good, you have to denote the time. Is it per year or per day? And it will be ideal if you base it on the simulation context. Secondly, the units, is it per person time or other person year or person day? That has to come out clearly because you will be asked that when you're going to publish this one. Just know it's 0.25 watts after how long. So please consider that. And then you mentioned, just go back to your diagram, model diagram. You've well captured the background depth. You just know that this is mortality, rather case fatality, and not morbidity. So I think that was a confusion from your end. You mentioned morbidity instead of mortality. And you have background deaths. We haven't seen disease-induced deaths. So what does that mean? Did you get that, Vicky?
Yes, I did.
Yes, so probably you might want to consider disease-induced deaths. Secondly, in modeling, if you're including background processes or other demographic processes like births and deaths, it helps so much when the disease is chronic. So how long is a person expected to suffer, on average, to suffer fistula? If the period is short, I would rather you make them negligible. You just do away with them because they will cancel each other out. And here we assume that the rate of influx for the susceptible is equal to the rate of, based on demographic processes. Otherwise, they will disturb you in your model. So, but you need to consider that. Secondly, the time to recovery is very important. And we had a discussion on the mathematics of your model. If you haven't captured the time to recovery, then explaining to someone that delta R is the recovery rate might be difficult. So on average, how long does it take for someone with fistula to recover? So then we have the complement as the recovery rate, and you have to include the units. Let's go back to the table again. So this is a deterministic model, yes, but it is very dangerous having only one parameter source for each of the parameters. Very dangerous. Why? It now beats logic on your research component in terms of literature review. And it seems like you're cherry picking your parameters. So if it's a deterministic, you need to do a well-structured literature review. But then you have parameters or other data or other papers within Uganda or areas of similar settings like sub-Saharan Africa, areas that mimic Uganda. You have those papers and then you get all those parameters and use them, use the average. And that is very important because we saw that you haven't shown us how you conducted sensitivity analysis for your parameters. Sensitivity analysis for parameters, one of the ways is to confine it within the parameters from the data sources that you got. So just 2.5, 0.25. If this was a special population, how will you compare it to Uganda, the entire Uganda? And probably that could underpin the reason why your results will not mimic the national statistic. So just be cautious. This is not quote unquote allowable. Just go back to literature, try and find other parameters. The good thing is that you have the codes, you have the reporting format and everything. So that then you have your parameters as average of all those data sources that you've gotten. And when you're conducting sensitivity analysis for your parameters, you make sure you have a justification for it. The lowest was this, the highest was this. So the lowest expected is this. Go back to your model diagram. So yes, you mentioned the rates. Some of them could be probabilities, some of them could be proportion. And we are seeing scenarios where you're multiplying some of the quote unquote rates. How are they multiplied? Under which mathematical law? That is very important. If there are probabilities, how did you conduct that conditional probability? Were they standardized with the denominator? What was the denominator? And those mathematics are very important when you're defining your parameters. You have everything figured out. You have the flow perfectly figured out. But the small things, you now have to brush up the small things. How did you come up with this parameter, specific parameter? So those transition parameters, as we discussed last time, so make sure you have a section in your Word document on the model description of your model and the transition parameters, or rather the transitions, and each and every parameter, where you collected them, and how you use those parameters to come up with a transition rate. If it's a probability, then there's a conditional probabilities here. There are conditional probabilities here. How did you calculate those conditional probabilities? So those assumptions have to be clear, especially as you're heading to the publication. So let's go to the results. Next page. Next. Now, you're telling us you have 50% of deaths public, or rather 42, 58 in private, and 10% home. It has already been mentioned that this will not add up to 100. Still correct that. And you're coming here giving us crude values. It is expected that a public facility sees more patients than a private. You cannot compare because these values are not standard. 28 out of what? If you do these calculations, probably those are lesser cases in a public compared to private. So if you're going with this, please make sure you convert them to proportions. So then we see out of 100 cases, how many fistulas are we seeing in the public compared to private? Private could only be seen maybe 10,000 vis-a-vis 500,000. Then public are definitely performing better in the sense of health facility readiness to combat fistula. So please take note of that. The crude numbers, they might give a false impression that public are not performing well, but out of what? Yeah. The same way, if you have 50 cases of COVID in Uganda and 40 cases of COVID in Kenya, and then you say COVID in Uganda is worse than Kenya, yet the population of Uganda, probably in this case, is twice the population of Kenya. So the burden has to come out clearly. And then go to your simulations. I think it's the previous page. The scenarios, where you highlighted the scenarios.
These are the scenarios, maybe
Yeah.
this one.
Yes. So the initial scenario, you got it from the prevalence and you converted it to mimic the number. Yes, that's a justification. But ideally, it should be the status quo for your parameters. The status quo for your parameters should be your initial scenario. So that then from those parameters, your model should give you the numbers that Uganda are reporting. So that is very important. The initial scenario is the parameters that you got, and that is the status quo. And if it's the status quo, your model output should be something close to the numbers reported in Uganda. So then as you're improving the fitness of your model, you're using those numbers output and refining the parameter values based on, again, the list of parameters, not just single parameter, the list of parameters you got from your literature. So now, after your parameters are correctly predicting the actual value, and then you start deviating around from the list that you had. And now you're making sure that the asymptomatic state and stability of your model is there, and there's no compartment at whichever parameter combination, there's no compartment that is giving us negative values. Now you proceed to your simulations. What if 50% vis-a-vis 50%? And because you are doing a research, you would rather make the steps smaller. This is reporting output. So I presume you had the steps smaller in a sense that you started at 100% all the way to 0% for each of the three, public, private, and home. So then you see how they oscillate and give us the convergence point. Convergence point plus other points that lead to the same convergence should be the one that is being reported. The lowest convergence point is the one that should be reported. That if we have 70%, 20%, and 10% public, private, and home, respectively, at least, then we'll have reduced the number of fistula cases. Just go to the graph with your output.
Pardon?
Yes, this graph. I think, yeah, any of the graph. Now, yeah. Can you hear me?
Yes, I can.
Yeah. Now, I want us to think together, do this together. We are having people getting into the susceptible, right? Because your model should actually communicate to the real scenario in approximation. Of course, cannot be perfect. You're having people getting in, and you don't have any intervention. Yes, people are not going back, but people are still coming in. Now, what explanation can you give to the hike and the decrease? If you're going to describe your results, how are you going to discuss that we had a peak in the second and a half year, then decrease? If we go back to the national data or statistic of fistula cases, does this mimic the real scenario? Do we have an intervention somewhere? And that is very important. Fistula is a rare event in terms of the proportions. So if you do this in proportions, and if you check papers that have done it in proportion, or other incidence rates, it will be almost somehow flat. Why? Because those numbers are believed to be oscillating around a certain point. I don't know how we are going to explain this graph that we had a peak at year 2.5 and the decrease. Why increase and then decrease? Are we having a reduction in number of susceptible? And why are we having? Is it because people who are recovering are not going back? That is not possible because it is confined to certain age groups. So does it mean that at a certain point after 2.5 years, we have less of, is it 15 to 19 years, less of 15 to 19 years in Uganda? So I think, I don't know the explanation to this, but I was just trying to think hard. This should mimic the real scenario if you're going to discuss your results. Finally, in your recommendations and limitations, I don't know whether you have limitations. You should consider thinking of something around the model. Probably someone might want to include a structured model. You might have seen that it is important and recommend that. Limitations, what limitations do you have with regards, did you experience with regards to the model? I think it will be imperative to include that. Thank you, Vicky. Thank you, Adam.
Thank you, Robert.
Robert, this was extremely helpful, extremely helpful. Actually, as you kept speaking, I've ticked 3 of the issues I wanted to share. Letitia also hinted on one, and then Rebecca hinted on the other as well. So I am left with I think 3 issues to share. Again, this is the purpose of not having a rushed discussion. And when we did a mid-term review, mid-review from, and you people suggested that we should have a detailed discussion. I think we can now see the value, because we are now going deeper into each one's presentation, and we see, okay, and we are seeing how we can improve it. And again, like I requested, Victoria, please take a lot of notes such that we go and you improve your model and we finalize it. Let me take it from the angle of Minister of Health, or let me take it from the angle of a policymaker. Okay, I think before that, let's go to the slide where there is a prevalence in the urban, no, in public and private. Like Letitia stated, Rebecca, Victoria, you're going to be very clear from day one, from the beginning, that what I mean by a public facility, I mean this. What I mean by a private facility, I mean this. Once you're that clear, that is going to help us a lot. Once we are stating these results, we are stating them the way they are here. I wish you could do this. I don't know whether you use the R or you use the Excel, but it's important for you to state the data source. Is it by UBOS? Is it or UDHS? Or it is something? It's important to state the source of this information. And it's important to state either in your presentation or even in the talk, either in your talk or in the presentation here, which years are we considering, which period are we considering regarding this reporting of the prevalence of the fistula cases. And it would be very nice for you to show the geographical distribution of the fistula cases across the region. That information could be available, but either in your background talk or what you need to bring it, you need to bring it out. Now, the other thing which you need to link fistula occurrence. In other words, the new fistula cases, which actually you are modeling, and the issue of health facility deliveries. In your talk, you did not link the two, because the health facility deliveries is an intervention to reduce the new fistula cases. So in your presentation, you should be heard speaking like that if we have this number of deliveries in this place, this is how many fistula cases we will save. This is how many fistula cases we will not see, or we will only see this number of new fistula cases if at all we have this number of if we have this deliveries happening here. And in your model assumptions, I don't know whether we missed or I missed your presentation of the model assumptions. You need to state what do you expect, what do you suspect the health facility deliveries to look like in a public setting? Do you expect midwives to use a pathograph? Do you expect them to use this? Do you expect them to monitor labor? Do you expect them to document document the labor progression on the pathograph? Do you expect them? So that detailed information in your assumption is very important in the interpretation of results later on. Even in the background information, it's important for you to tell us what the current efforts are by Ministry of Health in fighting fistula or in reducing the incidence of fistula. What is the Ministry of Health currently doing? If we are saying there is a pathograph being emphasized across various health facilities, how has it been? Have we seen any reduction since it was introduced in 1970 and before, when it was not introduced? What about in 2012 when they introduced an e-pathograph? How is it doing? How is it doing in a private settings like a Mengo, Rubaga, and Kampala Hospital and Novik and so forth? And how is it doing in a public facility like Mulago, like Chirudu, like Mulago Specialized? That kind of background information is extremely very important when you are modeling and when you are putting up the assumptions. Now you proceed to the next slide. You proceed to the next slide. Go to the simulations. Now let me now go speak as a Minister of Health person. Yeah, you can stop there. Victoria, what makes sense to the Minister of Health is the following. And it may be an additional question, or it can be a question you can report on. This is what makes sense to Minister of Health. We are telling them that, look, currently, the health facility deliveries is at 67% in public and 27% in private. This is the actual burden of the fistula cases. This is the actual burden of the new fistula cases. Now you are modeling. You are now showing how many fistula cases that happen on a daily basis, given the current low hospital births that we have. Now that becomes your baseline, and that's what Robert was referring to. That becomes the baseline. Before you begin making a case that if you increase deliveries to this level, if you increase delivery to this level, this is what we shall see. The first baseline is that, look, the current hospital delivery is at 67% in public and 22% in private. This is what the model is showing as fistula cases. It is very likely that the model output is likely to have a higher number than what is reported in the records of Ministry of Health. And that is very important for you to document that, look, our model is showing that there is possibility of underreporting of fistula cases in various places in the health facility. There is a possibility of underreporting it. And so you can make a recommendation there that either there is need to follow up or there is need for increasing vaginal investigations, or to see how many fistula cases we are seeing, or there is need for being very intentional or training midwives on detecting or identifying fistula cases. Now, if we can know the current number regarding fistula as per our model, and we are using that as a baseline. We now tell the Ministry of Health that if we want to have 0 fistula cases, this is the level of hospital deliveries we should have. I don't know whether Victoria, you're following me. So in other words, you are turning the story upside down, or you're speaking in the other way around. Minister of Health wants to hear answer. They want to be told what to do. You're telling them that because what they don't want to see is they don't want to see fistula cases happening. That's the burden to them, because the cost of maintaining, the cost of repairs, the cost of treating them is very high. So you're telling them that, look, health first deliveries could be an intervention to this big burden. And it can be a good intervention if we increase the coverage, if we train the midwives, if we use the pathograph, if we roll out the e-pathograph. You are either using this part of the things you put in assumptions or part of the model outputs that you're having right now. The first thing you've told them that there is underestimation of the current burden of fistula as per my model. That is number one. That's the first level. The second level, you're telling them that if we don't want to see any fistula case in Uganda, we need to raise our health first deliveries up to this level in a public setting and in a private setting. Actually, we should be silent. We should be silent about promoting any deliveries at home. And we should be silent about promoting any deliveries in private settings. But that's what Robert was saying, that what is the current picture? You go to next, go to your last simulation, the last slide before you went to interpretation. Yes, there. And that's what Robert was asking, that what is the current picture? Because when you're stating the results, you try to relate with the current picture. Because if we know that the current picture, it has a high deliveries happening or being documented in a public setting, then your model, and it is, okay, your model, okay, in your scenarios, you're putting 90% in private and 10% in private. Either they will assume that the private facilities are the ones who funded this study, or there is something you are promoting in private settings than the public setting, and that's very bad. Remember, it's the Ministry of Health which gave you money for this fellowship. They want you to tell them what they should do. So you should be able to model, not by asking the results per se, but what are we seeing in a public setting? What should the Ministry of Health do? So if the current coverage is high in public setting and private setting, so in your various scenarios of increasing coverage, you cannot turn tables upside down. You cannot say, okay, the current coverage for hospital deliveries is 67%, private at 22%. But in my next scenario of improving the hospital deliveries, let's have 80% private and 2% public. It doesn't make a lot of policy sense. So what I'm saying is that you need to you may want to report differently, or you may want to probe your model differently, or you may want to read, instead of reading from the x-axis alone, you want to read from the y-axis alone. If we are to have 0 fistula cases, if we don't have to have 0 incidents, 0 new fistula cases, to what level, to what coverage of hospital deliveries should we have in Uganda, in a public setting, in a private setting? If you can ever mention that, that's what the Minister of Health wants to see. That's what the DG wants to hear. That, look, you know what, people, we are struggling with the fistula because partly there is no well tracking of deliveries, but also there is less hospital deliveries. Our mathematical modelers have told us that if we want to see 0 fistula cases in the hospitals, we should have 99% public health deliveries, and we should have 70% private facility deliveries. Number 2, we need to have consistent and effective use of the pantograph. Number 3, we need to train the midwives for them to progressively manage labor and ABCD. Now, that is what you put in recommendations. That is what you put as areas for future research. Your recommendation is, and of course, I'm not blaming you because you're coming from the statistics background, but you need to sit with Rebecca and Alice and Lydia, and they help you to put our recommendations in context of fistula management and what intervention the Ministry of Health needs to do. I don't know whether that makes sense to you, Victoria, because what right now you're showing is that under scenario 1, when I have hospital deliveries at 58% in the public and 42% deliveries in private, I am going to have 41 cases of fistula. Ministry of Health doesn't, first of all, they're going to feel bad if at all the public deliveries, the current deliveries is at 62. I don't know how the number now, but if it's at 62 and you're saying scenario number 1 is at 58%, they first switch off there. They will tell them 41 daily cases, they get angry there because they want to see 0 cases. And that's what Robert is saying. You need to have a baseline that right now, we are at 67% hospital deliveries and 21% private hospital deliveries. So we now have this number of fistula cases. Although our documentation captures only this number, but we are missing out 22%. That is a very good groundbreaking finding from your model. That's extremely excellent. That's level 1. And you're telling them message number 2. If we want to see 0 fistula cases in public and private facilities, this is the level of coverage that we need to have. Now, that is now message number 2. Then you tell them, but I made this assumption of us having 99% and zero occurrence of new fistula cases on these 3 assumptions. Assumption number 1, that pantographs are well distributed across the whole country. So if they are not, Ministry of Health, let's distribute the pantographs. Number 2, I assume that midwives know how to use pantographs and they know how to monitor labor progression. If the midwives actually don't know, or if we don't know whether they know, either we should do a qualitative study to know whether they know how to use a pantograph, and we explain that, or if we know they know, then we should either have refresher courses or CPD in health facilities on pantograph use. I also assumed that the doctors are always available. Maybe to give guidance or something like that. And if we know that the doctor ratio is this to this, and they are missing in some places, so we recommend that Ministry of Health please either deploy more medical officers or gynecologists to help follow up this issue A, B, C, D, X, Y, Z. So Victoria, for me, that is my feedback, and that is what should come in your discussion of results and in your conclusions, in your recommendations and the limitations of your work. But having a baseline because you need a baseline before you tell them that if we increase to this level, if we increase deliveries up to this level, we will see this level of improvement. We need a baseline. We need the current picture before we begin intervening, before we begin increasing, before we begin training and sensitizing. What's the current position? Victoria, does that make sense to you?
Yes, it does.
Okay.
Thank you.
Yeah. Robert, go ahead.
Abel, mine is just to encourage Vicky that don't Don't think that you're far off from completing. No, from my assessment, honest assessment, you're 75% there because you understand the flow, you've gone to the end. But if you paid attention, a lot of comments are on the technical component. Now you have to wear that your professional background, statistics. Go hit your technical, and then work together with those in the Ministry of Health to refine your discussion and recommendation. Otherwise, this is good. Don't feel as if it's a burden. If in any case, us Kenyans are the one facing a burden right now, as you can see. But you guys are okay. You're relaxed there. So tomorrow, please join us online in our fights. Thank you.
Yeah, thank you so much. Vicky, this was very good. Please improve it. And once you have an updated work, you share it before 2nd of July, such that we present to the GATES team as well. Members who joined in a bit late, we have a progress meeting with the GATES on 10th of July. We are requesting for you to share with us the updated PowerPoint. By 2nd of July, you copy me and Anita, such that me and Anita, we can work on the presentation ahead of 10th. Thank you so much, friends, and we will stop here now.